All right. Welcome back to the Midland Health Podcast, healthcare that makes you proud. This is, I believe, our 6th episode that we're recording. Really excited to be doing this for the community, this series here in 2026. I do want to ask everybody, we're getting a lot of views on YouTube and Spotify and Apple Podcasts. We're really appreciative of that. We do want to ask everybody to subscribe to our channel wherever you're watching or listening to the podcast. We're at about 841 subscribers as of this morning. Our goal was to get to 2,500 subscribers by the end of the year. So please hit that subscription button. Also, leave comments if there are guests you'd like to hear from or topics you want us to cover. We've still got some open spots throughout the end of the year for some of the episodes we're going to record, and we really want to bring content to our listeners and viewers that are of interest to you. So if you'll drop a comment, we'll try to address those comments in future podcasts. I'm really excited today to have Val Sparks with me. Val has been the infection prevention coordinator at Midland Memorial Hospital for 34 years. She's one of those institutional knowledge people. She knows everything about the organization, why we do things, how we made this decision, sometimes she's one of those 4 or 5 people that's like, why did we do this? It's called Val. She'll know. She's been certified in infection control for the past 31 years. Val has her MSN in infection control, surveillance, and epidemiology. She has given numerous presentations on infection prevention and is the subject matter expert for Midland Health on this. She's married to Jeff. She's mother to Jared, Josh, Justin, and Christina. She's Gigi to 9 precious grandchildren, and she's active in First Baptist Church Choir and a nursery volunteer. She's a member of the Manor Park Board of Trustees and the Community Children's Clinic. So, Val, welcome to the show.
Thank you.
So, I did a little introduction there, but tell us a little bit about yourself, your role at Midland Health.
Well, I started as a nurse. I am a nurse. I've been at the hospital for 42 years
42, I said 34.
in infection control,
Okay.
but I've been at the hospital for 42 and started on the med-surg floor. I have worked in the blood bank. I've worked in oncology, the outpatient oncology clinic before it separated from the hospital. Did numerous blood drives in the lab, ran that for several years. And when it was time to come back in-house, infection control was a sole one-person position. And I took that position, like I said, 34 years ago. And we've grown it. I now have 4 full-time surveillance individuals, nurses, analysts that help with all the mandatory reporting, and looking for hospital acquired infections, make sure that the hospital is doing everything we possibly can to prevent any type of hospital acquired infection.
Good. And you have a whole team now.
I
So
do.
that's
I do.
important. I think the message that we want to try to convey, and there's nobody better to do that than you, is to just let our community and patients know that we take this stuff very serious, and that we have an investment and a process that we follow to try to reduce and eliminate infections in our hospital. There's a long history of myths of, well, if you go to Midland that you get infections, and we've talked about it in board meetings. For my 17 years there, like, we would look at data and say, these numbers are really good. Why is that? Why are those myths out there? And I think, I don't know what happened here a long time ago. You've been here 42 years. You may know that there was a time that we did have a lot of infections. But I think that's the message that we want to convey to our patients today and the community, is that this is something we take very serious, and that we do everything we can to reduce, minimize, and eliminate infections in the hospital. 42 years at the hospital. You must have started very, very
I was
young.
2.
Okay. That squares. I think I get that. So let's jump in feet first and talk about, and I know you're good at this, talk in layman terms about infection prevention, what all you and your team do in the hospital as it relates to infection prevention in the organization, and lastly, what's important for our listeners to know about infections.
Well, over the years, several things have changed. Of course, we have to do our mandatory state notifiable conditions reporting. So we've got all the reporting that comes out of the emergency room, whether it's any communicable disease, whether it's tuberculosis or measles or COVID. We survived COVID, influenza, malaria, anything that meningitis, anything that the state deems as notifiable. So we start there.
Because they want to look for outliers.
Sure, they
You
do.
know, we
Sure, they
have
do.
one of
Outbreaks.
these in Midland a year, and suddenly we've had 4 this month. Is that something that the
Oh,
state needs to take notice of? Yeah.
absolutely. Absolutely.
And we've had the measles outbreak in the last, I guess, is about a year ago. Didn't hit Midland really hard, but it certainly hit West Texas hard. And the state was able to see that kind of coming and took some action to hopefully help with that.
And
That's why we report those things.
that's correct. That's correct. The other thing we do in infection control is we, because of CMS, which is the Centers for Medicare and Medicaid, they have some mandatory reporting that all acute care hospitals have to report. And of course, there's reimbursement
Mhm.
tied to that. So they kind of set thresholds, and there's certain key things that we have to look at, we have to do. One of them is called CLABSI, and that's a central line associated bloodstream infection. And that what this is a line that is put in either in your neck, in your jugular vein, in a subclavian vein, or if it's peripherally inserted, we call that a PIC. Anything, a dialysis catheter, all those types of lines that we have to monitor so they do not end up with a bloodstream infection. The other thing we do is a catheter-associated urinary tract infection. This is called a CAUTI, and those are another line that goes into the bladder. It's inserted in males and females, and of course, it drains your bladder, drains the urine, and we're always monitoring to anytime we can get that out. We do have mechanisms in place to a nurse-driven protocol to get those out. You can't get an infection if you don't have a line in. We have external catheters that we use to help keep our patients comfortable and dry, and continue the medical care to monitor your urinary output as well.
I know in the last few years that I've been in the CEO role, I've learned a lot about CLABSI and CAUTI, and there are certainly times where there is a need for a central line or a catheter, but sometimes they might end up there for a good reason and then maintained there for convenience.
Mhm.
I know I've had talked to a lot of patients about we're a briefless hospital. We try to minimize putting patients in briefs, adult briefs.
Correct.
But the number one way to eliminate those are to eliminate central lines and catheters, and only use them when they're absolutely necessary.
Correct. And the majority of the time, this is in critical care.
Right.
And that nurse to patient ratio is 1 to 1 or 2 to 1. And they truly are being cared for round the clock, 24/7. The nurse spends a lot of time with that individual. They are critically ill.
Hmm.
And we have to have those in order to keep the patient safe and comfortable. We do monitor ventilator-associated pneumonias. So we have a whole protocol with cardiopulmonary and our intensivists to get the patient off the ventilator early. It's called a sedation vacation, waking patients up, taking them off of sedation, letting them see if they breathe on their own, working with movement, keeping the head of the bed up, suctioning, doing everything we can to prevent pneumonias when they're on the ventilator. Another thing we monitor is methicillin resistant Staph aureus. We call it MRSA.
Hmm.
Staph aureus is a normal flora. A lot of people carry it in your nose or on your skin. Methicillin is an antibiotic. It's like penicillin, nafcillin, certain antibiotics that we use to treat minor infections. And this bug adapts and becomes resistant. So therefore, we have to use bigger, more expensive drugs, vancomycin a lot of the time, daptomycin, that are used to treat skin infections or, heaven forbid, a bloodstream infection. Another one we monitor is Clostridium difficile. Clostridium difficile is
C.
a
diff.
yeah, is C. diff is a poop bug.
Yeah.
It is found in your bowels. It's kind of normal flora. It can be. And what happens, how people get this is overuse of antibiotics normally. we change the pH or the normal flora of your bowel system, thus causing severe abdominal cramping, diarrhea, and other abdominal signs and symptoms. So we always try to prevent that if at all possible. We work with pharmacy on antimicrobial stewardship, making sure we get the right drug for the bug. We don't over medicate. We get the right dosage for your body weight. And we switch from IV to PO as soon as possible, and to even discontinue those antibiotics if it's not the right, if it's identified as not being the right medication for that organism that's identified. We do have to report that if we have hospital-acquired C. difficile. So, we do have nursing protocols in place that is based on the monitoring of the nurse charting and the number of stools they're having, the type of stools they're having, that will trigger an order, for the stool specimen to be sent and to test for that colonization or infection. Another one that we do, of course, is we're always monitoring certain surgical wounds. CMS mandates that we do our colon surgeries and our hysterectomies. Now, we monitor a lot more for DNV. DNV, of course, is our Det Nors Veritas,
Very good.
that is our
Accreditation.
accreditation. Yes, accreditation. And they come every year and inspect us. Um, but we are certified for the total joint center. So we do all the total knees, all the total hips, all the total shoulders, and our spines, our backs, necks, and all of our spine surgeries. In addition, we monitor our C-sections. Those two ORs, I like to keep a pulse on all of our ORs. And those two ORs are in the labor and delivery suites. And those are the procedures that are done in those areas. So we monitor those C-section infections, which is very, very low, by the way. We also have our CVOR. We monitor our coronary surgeries, our heart surgeries. And there's two OR suites downstairs that are done. Most of that is all of the cardiac surgeries. The remaining of the surgeries are done upstairs on third floor. And we're up to 16 ORs now upstairs. And so we just continue to grow. Our procedures continue to increase. We have all the robotics, the Da Vinci.
3 Da Vinci robots,
Yes,
2 Bacos.
it's amazing what we can do now. We can do a colon resection, all robotically, and you don't have a big incision to deal with. We can do hysterectomies robotically, and they're same day surgery.
I know on those surgical site that we watch, a lot of those are for inpatients that they're
Correct.
looking at, and a lot of our hysterectomies are outpatient now.
Correct. We only did 43 inpatient hysterectomies last year.
That's a low number. Do you know
Lowest
what
number
percentage that
ever.
is?
It's very low. I can't tell
Yeah,
you the
a lot
percentage.
of that stuff, I know it just a long time ago, you were in the hospital 3 days, and now you go home
Correct.
the same day, and it's because of the robotic advancements and the minimally invasive surgery that you can recover a lot quicker and go home.
Same way with our total knees, our total hips. Most of those are same day.
Yeah.
Not
long ago, you were in the hospital for 4 days, then you had to go to rehab for a week to
Correct.
recover, and now you're going home same day.
And Midland Memorial is I like to say cutting edge. We have all those robots, we have all those things that we can get you in and out, and have successful joint replacements, hysterectomies, and I mean even C-sections are basically a day and a half anymore.
Yeah.
Yeah,
A couple of things that you mentioned that I want to hit on. One on the DNV, you talked about the they're our accreditation agency for the hospital. They come every year. They're also our total joint center is accredited by DNV, but also very important to you is our sterile processing department is of one of only a handful of
We
hospitals.
are the only one west of I-35 in the state of Texas.
Yeah, the only hospital west of I-35 that our sterile processing department is certified by DNV. So they come every year as well. They were just here a few weeks ago doing every 3 year, they do a very deep dive. They were here for 3 days going through our sterile processing department, looking at our processes and procedures, looking at the training that we give to our staff, looking at what happens in the OR when those instruments come down. But all the instruments that are used in the OR and C sections have a very rigorous process that they have to go through to be clean so that we can use them for the next case. And so we made the decision probably 3 or 4 years ago to
Yes,
become certified by DNV, to really to give our physicians, our staff, and our patients assurances that we follow best practices in how we run that department, and that helps cut down on
infections.
infections as well. The other thing you mentioned a couple of times was hospital acquired. Tell us what that is and why that's important.
Hospital acquired means it was acquired in the hospital
Mhm.
as an inpatient. You didn't come in with it. It wasn't present at time of admission. It wasn't present at time of surgery. And it develops as a result of a procedure, a line placement, or something that has an outcome that needs to be treated. Most of the time, it's an infection that needs to be treated with ongoing antibiotics, that type of thing.
And hospital acquired's important because that's what we're held, the standard that we're held to.
Correct.
Not again, not very long ago, people came with infections or they acquired an infection and we dealt with it. And now that we're really held to some kind of standard on this, we make sure that we test people that come into our organization.
Correct.
There are any signs or symptoms associated with any of those infections that you talked about, because if they come from the nursing home or they come from home or some other organization, they get transferred to us and they already have that, we need to make sure that we document those patients
Correct.
came with this infection. They did not acquire it while they were in our hospital, and that doesn't count against us.
Correct.
But
My
we still
role,
treat it and take care of it when they
correct.
show up
You
here.
know, it over the years that I've been doing this, I started in infection control. And now it's called infection prevention and control. We always try to prevent infections first. And if we have to control it, we will.
Yeah. Good stuff. Thanks for
Mhm.
covering those kind of baseline things for us. So our goal as a healthcare system, I know it goes back many years, starting as I remember it with Lori Wesley, who was the chair of our quality improvement committee of the board. And we talked about some of these standards that are set for us on how many MRSA infections should a hospital our size have with the number of patients, how many CAUTIs and CLABSIs based on the lines that you have. And I remember Lori saying anything above zero is an unacceptable goal for us. And so our goal for many, many years has been zero infections. That's a
Correct.
very tall order,
It
but
is.
anything
It
saying
is.
anything more than that is acceptable. I think that kind of speaks to our culture. Anything more than that is really not acceptable to us. So it takes a real team approach to minimize, reduce, and prevent these kind of infections in our organizations. And there's a lot of contributing factors. Let's talk about the team approach to zero infections, not just what your team does, but how do they work with nurses, physicians, respiratory therapists
Mhm.
to prevent, minimize, reduce infections in the organization?
We are always using guidelines that are out there, whether it's the CDC, AORN, which is the Association of Operating Room Nurses. The anesthesia providers have a organization that they use. The surgeons have a organization that they use. We use APIC, which is Association of Practitioners in Infection Control. All of these organizations have guidelines, and most of them are all evidence based. They've been proven through research, meta-analysis, et cetera, that this is the best way to prevent a hospital-acquired infection if you're doing XYZ. We're working with anesthesia on ERAS, which is early recovery after surgery. We work with the preoperative testing center to do all of our preoperative bathing and showering. We're teaching individuals about smoking cessation. We're talking about do not remove hair. Everybody wants to have clean shaved legs before they come in for that knee, and do not shave your legs because it leaves micro little tears, or you can
In your
cut
skin.
yourself in your skin and
A lot of
breaks that.
opportunities for infection to
Correct.
come in. Yeah.
Correct. So we don't want you to shave, okay? We don't even shave you, okay? We use clippers, or we don't shave at all. That is really the
Depends
best.
on the procedure. Yeah.
Depends on the procedure,
Yeah.
correct. And it would be as close as possible to the time of surgery, okay? Not 2 days before. Of course, we all use pre-op antibiotics. The timing of those antibiotics. We don't continue antibiotics post-op unless absolutely necessary. Normally, the maximum amount of antibiotics you would get normally is 4 doses before, during, and immediately after, and then 1 if you're spending the night. If it's a same-day surgery, you may only get 1 antibiotic preoperatively. Of course, we're teaching about dressings postoperatively, how you care for those. We talk about if you have animals in the home, how we keep the animals away from animals are kind of, especially dogs, are drawn to the wounds, or they want to lick and heal you and that kind of stuff, and we don't want
Bad
that.
news.
Keep that dressing in place. We don't want you bathing or showering unless the physician tells you you can do that with the dressing on. Keep the dressing on as long as the physician tells you. Go to your PT, care for it the way they tell you to care for it.
Follow up with your primary care provider.
Absolutely.
Or a
Follow.
surgeon if you've got to see him. Make sure you go. Those things are really important.
Take the medication that they prescribe for you. Take all of it.
Yeah.
Don't keep it for later. Okay. Other than pain medication, we're really trying to cut down on the pain medication too. We have a whole system, but that's not necessarily infection control,
Right.
but it is for best patient outcomes. Okay. So those are types of things that we do. In critical care, we do, if you have those lines and because you're susceptible to a change in normal flora, we do CHG bathing of you in the critical care unit. So if you're on our 5th floor, you're going to have bathing with a special soap. And so that is done on you while you're in our critical care 5th floor area. We don't do it house-wide, but we do it because of the risk with all the lines, the ventilators, the central lines, the urinary catheters, maybe open wounds, etc., that you may have while you're in critical care.
Okay. And I think we haven't even talked about, when we talk about the team approach, we haven't talked about our housekeeping department. What an important role they play,
Correct.
not just in keeping our lobbies clean and the elevators, but they're responsible when a patient gets discharged from a room
Correct.
and we're getting ready to readmit a patient. They go through a process, a very rigid process to get the room clean so that it's safe for the next patient to come in. Can you tell us just a little bit
Sure.
about what they do?
I'm involved in what disinfectant they're using. Whether what EPA approved disinfectant, what it kills, what the contact time is. The EVS personnel know this like the back of their hand. We also have given them UV lights that we use in all of our 5th floors, in every OR, in all of our isolation rooms. We use that throughout the hospital to not just do the basic EVS disinfecting, but we also utilize the ultraviolet lights within those rooms to make it as clean as possible for the next patient.
We were one of the first hospitals to acquire those UV lights and start to use them. They're pretty standard practice now, but I remember when we acquired those, they came to our capital committee
And
for
we're actually on our 3rd generation, and we have now like 1 or 2 in the OR. We have them in CVOR. We have one housed on 5th floor and throughout the facility. So they really are used
Yeah.
all over our facility.
Good. Okay. Shout out to the housekeeping department.
Yes.
So there's a lot that goes into each and every patient encounter. Every patient's different. While they're here, maybe a little different. Uh, but there's so many pieces to the puzzle in delivering the best patient care that we can to our patients. We want to make sure that they have high quality outcomes. Let's talk about some of the wins that our hospital has in our infection prevention work. And let's, in full transparency to our patients, let's talk about a couple areas maybe where we're working to deal with some challenges that we have.
Yes. Some of the wins, the big thing is the catheter-associated urinary tract infections. It just continues to go down year after year, our numbers, and we are way below threshold for CMS. And I think that's due to the nursing, the physicians getting on board with these external catheters. That has been a huge win for us. Now, not a cheap win necessarily,
Yeah.
but it's worth it. It's worth it. The MRSA, we have protocols in place, screenings, those types of things. We are below on that. And we're only looking at MRSA in the bloodstream. Okay. So they're not getting an MRSA in the bloodstream infection. Another win is our C. diff, our Clostridium difficile, that protocol that we have in place, monitoring the nursing documentation and the patient status as far as stooling, what I already talked about,
Yeah.
and getting those tests done, getting them isolated, getting the rooms cleaned properly. We have to use bleach to kill that. I know there's some things in the public now about cruise ships and
Oh, yeah.
norovirus. Things like that. And I mean, you have to use bleach. We don't use bleach normally to clean in a hospital. It's very corrosive. It's got an odor. We don't use that unless absolutely necessary. And C. diff is one of those things that we have to use bleach on.
To kill it.
Yes, to kill it. And it takes some time to do that. Um, we've done very well on our C-sections. Our C-section infection rate is very low. We have glue now that puts patients back together. We don't use staples or sutures in a lot of the cases. Same way with our total knees, our total hips. The Everything that we do now is the least invasive that we possibly can, and to hold it together.
Yeah.
Also, even in our sternal wounds, in our cardiac surgeries, we'll use glue at times, and the dressings to hold it together. We are, like I said, very good on our total knees, our total hips, our spines, shoulders, no problem at all. We do have, we continue to work on our central line associated bloodstream infections. My team is rounding twice a week on every line, whether it's a dialysis, a PIC, or where it's placed, to get these lines out, to keep those dressings intact. They're not in real comfortable places
Yeah.
where these lines are. They're bulky on the neck, or they're in the groin area, and it's just hard to keep those dressings intact. We have a new system now with the glue and advanced dressings. There's 7-day dressings. A lot of times they will hold, a lot of times they won't, depending on the patient being diaphoretic, sweating, um, um,
Getting transported
yeah,
for this, that.
transport
Yeah. Yeah.
moved. Yeah, they have to go to MRI or they have to go to CT. All that line movement, and in addition to ventilator tubes, ET tubes, that there's a lot of stuff in medicine that we use to keep people alive and to help them get better, and it's just very invasive.
Yeah.
But we do work on that. We work with the nurses, we work with the physicians, looking at what medications are they getting? Can they be given peripherally? Do they really need this medication or antibiotic? How long are they going to be on it? Can we move that line from the neck area to a PIC line that goes in your upper arm or your antecubital area?
A little easier to manage
Little
that.
easier to manage,
Keep
keep
clean.
dry, keep clean, those types of things. End caps. We have antimicrobial end caps. They've got caps on all of them. So if they're not a direct infusion going on, they are bathing in alcohol and CHG. So we try to prevent as much possible contamination at all.
Okay. When we do have an infection,
Yes.
tell us about what happens. What does our team do when we identify a patient that has a hospital acquired infection, one of the ones that you've talked about?
Through my team, because it is reported up through QM-SOC, patient safety, goes to the board. We do what we call is root cause analysis. First
RCA.
of all, RCAs. And infection control works with nursing, works with the physicians to see what could possibly have caused that break in our system, um, what underlying conditions were ongoing. Were they a diabetic and we had high blood sugars? Were they have other underlying conditions, with whatever? And we will look at those, list those out as to who was involved in the care. I mean, all the way down to the nurse that took care of them on that shift.
Yeah.
Okay. Is there documentation that they did everything per protocol, timely, etc.? And then when infection control rounds and could potentially find things that weren't 100%, We document that. We are working with the nurses. We're working with nursing leadership to be sure that those individuals are aware of what's going on, and that we are trying to do our very best for our patients, if at all possible.
Yeah, when we have one, it's a all hands on deck. Like
It
the
is.
alarms go off, and we take
It
these
is.
things really
Mm.
serious. Again, the message we want to convey is there's a very significant
I
process,
right.
and I wouldn't say, again, not to our culture. It's not meant to be punitive to our staff. It's meant to identify failures and educate.
Right.
I would say though that if
And
we
competency, making
Sure.
sure they're
Yeah,
competent.
do have we taught them how to do this? Has it been
Correct.
a long time? Maybe they've been on the 5th floor, which can happen. Maybe they haven't had a central line in a while. Like, "Hey, we need to re-educate." So these processes, certainly in the beginning, aren't meant to be punitive. If we see a few
Ongoing.
infections and it's the same person all the time that's taking care of that central line or, that catheter, then there are different things that we have to go through to deal with that. But our initial approach in our culture is, hey, why? What happened? How do we educate? How do we prevent again? Make sure the staff have the tools they need, the education they need to
And
take
that
care of
that
their
is one
patients.
thing also is one of the questions on this RCA is, do you have the tools provided that for you to do your job?
Yeah,
Okay. I like to tell the nursing staff, you want to treat each patient as if they're your loved one. This is your spouse. This is your child. This is your mother. Whatever, whoever your significant other is, you want the very best for them, and you want to do the very best for that
yeah.
patient.
And I mean, we interact with our nurses all the time, and of
We do.
course, they all know that we're paying attention to this. They want to provide high quality care, but sometimes there's an issue in the system, and that's what Val's team does is we try to identify those and prevent correct those things
Correct, and
so
work
they
with
don't happen
nursing.
again. Yeah,
We're always looking at products. There's new things out there. One of the new things that we've got now is the glue. It's an antimicrobial glue that goes at the insertion sites, and it just helps seal it off and keep the bugs out.
yeah.
And so, there's always new things that we're looking at through the nursing team, through our clinical value analysis teams. That we're always
Yeah,
evaluating.
it's a partnership between the nursing staff, prevention, the housekeeping staff, the physician, you name it. Everybody's kind of plays a part in that, including the patient and visitors in there. And we'll talk a little bit about what patients can do to make sure they're in the best
Mhm.
position they can be in to avoid infections. So this is not the most fun topic to discuss, but I really thought it was important that we have this discussion because we think it's important that the community know and understand that we have a process. Let's talk. We hit on this just a little bit, but dive just a little bit deeper into some of these really big bugs. Legionella, measles is the one that I mentioned that we had a big
Mhm.
outbreak here about a year ago. Let's talk a little bit about those. Explain to our viewers why these are recent hot topics, and if there's anything they need to know or do to protect themselves from these bugs that are kind of back in the news that for a long time we thought were eliminated. There was no reason that we cared about measles and some of these things. They didn't happen. What can they do to prevent and protect themselves today?
So, starting with the Legionella, we have continually monitored for this. This is not new to us. We do see some patients come in with it. Usually, it's a pneumonia. It is caused by a bacteria, the Legionella bacterium. It usually comes from misting water out of cooling towers, out of shower heads. Mostly due to improper chlorination. We have a whole water management system at Midland Memorial involved with facilities, microbiology, an outside lab, and infection control. We are monitoring monthly our chlorine levels through currently 88 different places within our hospital. Um, and to make sure that the chlorine from the city and the central utility plant is going to the far ends of where the patients are interacting, getting that shower
Yeah.
or water.
Washing their hands in the faucet.
Correct.
Yeah.
Correct. We do outside culturing. We have no problem with Legionella. Um, like I said, most of these patients will have pneumonia. We've had no hospital acquired Legionella. It has come in from outside. And it is treatable with antibiotics. That's the good news. The other one that we've been focusing on, of course, over the last year is measles. This is a vaccine preventable virus. There is no antibiotic that we can give for measles. Um, the individuals usually will have general symptoms, they'll have the cough, the runny nose, conjunctivitis. The big thing is the rash that will start at the head and just go all the way down the body. We see this a lot of times in the unvaccinated, the young, or the elderly who have underlying conditions. Like I said, there is no bacteria or antibiotic for this. It's not a bacteria, it's a virus. It's usually self limiting unless it ends up in pneumonia or encephalitis, which is brain swelling, which can lead to severe complications or even death. Because it's so contagious, we had to do a lot with our air systems. We had to do a lot with our masking. We had big signs, don't come into our waiting rooms, get the mask on. I mean, it was a whole process to shut down the ER and to we had one hospitalized patient, and that is key to keeping that contained and not letting it get spread via airborne.
Yeah. Difficult conversations to have these days,
It is.
where this used to just really be standard, whether it's us talking about it or you're going to your, I know physicians have those challenges with patients today and
Yes.
with what's going on in the world, that there's a lack of trust in some of these things.
Mhm.
And whether that's well founded or not, it brings some of these things back to light that for a long time were not an issue in our country. And so
Mhm.
people get to make their own decisions here, and all we can do is try to provide, I think, the best information that we can,
Right.
based on data, and evidence based medicine,
Mhm.
and
Mhm.
then people make those decisions for themselves. And if you come to the hospital with Legionella or measles, we'll take care of you.
We are.
But
We will take care of
we
you.
we don't discriminate, so we'll do as
We will
best we
isolate
can.
you.
Yeah, we will limit visitors, and we'll do some
Y
things,
you
but
know, Mr. Bowerman, that's another thing that my team does is isolation, and a lot of times, the public doesn't understand why they have to put on a gown or why they have to wash their hands or wear gloves when they visit, or a mask
yeah.
when they visit their loved one, and I realize they may have been in their household with them and exposed, that type of thing, but we're trying to prevent, the spread within our facility to other, um patients that might be susceptible, or even our staff. So we're trying to do the best we can to keep it from spreading, whatever, whether it's meningitis or the influenza or COVID or measles. We do
Sometimes
tuberculosis.
that isolation will work both ways too. It's
Correct.
We don't want anybody coming in to give somebody that's compromised some other little bug that they're carrying that you don't know that you even have, because your immune system's strong and you're fighting it off. But we also don't want what our patients
Correct.
have to infect our staff and visitors and other patients. So yeah, that kind of goes both ways. Well, we're out of time, but I really want to thank Val for coming on and joining us. I think again, this isn't the most fun topic to discuss,
Oh, I
but
I
I think
love
it. I
bugs.
know you do.
I
Yeah, you
love
love it.
bugs.
She's like, anytime I can talk about infections and things we do, I'm happy to. And I call her often saying, "What is this? What does this mean? What are we doing about this?" And she always has the answer. But I like to end these podcasts with, what's one thing you would tell our patients that they should be doing to protect themselves from infections, whether they're in the community, they're at school, they're in the hospital. What are things that our listeners can do to prevent infections?
Well, my soapbox is hand hygiene.
Yeah.
So these little 10 things right here, you can wash them and prevent the spread of infection. You can teach your children young. We can teach it in the schools. We can teach it in our homes. Also, covering your coughs and sneezes. Get it into the corner of your elbow, if at all possible. Yes, your sports coat can be dry cleaned. Um, but try to prevent the spread of bugs. If you're sick, stay home. Especially if you've got fevers and you're hacking and coughing and sneezing, and it may just be the common cold, but it could be life threatening to an individual who is immunocompromised, or who is at church with you or whatever. So please stay home if at all possible. I like to recommend that you stay up with your primary care provider, do the annual checkups. I
Right.
know there are individuals that go, "Oh, I'm never sick. I don't need a doctor." Well, when you do,
It's good
Whether
to have
it's
a baseline is what I always
it
say. If
is.
you've been seeing your primary care doctor for 5 years, no issues, and in year 6, there's a little spike in your blood pressures, having that history allows them to see there's a change here. Well, maybe we don't need to be alarmed, but we need to pay a little closer attention. That's the message I try to
And
give.
we try to do preventative medicine, whether it's the mammogram or the pap smears or the PSAs or, the colonoscopies. We try to do preventative medicine to get us the healthiest community that we possibly can have. And it's out there for us, but sometimes we just need to take that first step, make that first phone call, and get in with a primary care provider if at all possible.
You heard it here from Val first. Our vision at Midland Health is to be the healthiest community in Texas. And the best way to do that is to wash your hands. I tell my kids often the most important things you've learned in your life, you learned in kindergarten. And washing your hands is something what
It
you've heard it
is.
from Val. You probably heard it from your kindergarten teacher. Like it's a really good practice. So please do those things. Well, Val, thanks for joining us and discussing these topics. I'm sure hopefully we'll get a lot of comments on this from our listeners. I think again, it's not the most fun to talk about, but it's something people have real interest in, and rightfully so. You're going to come into the hospital, you want to know what kind of things are going on there to make sure I don't get sick when I'm sick. I don't want to catch something that I don't have when I'm there. And that's a reasonable expectation for our patients. So I think telling them that all the things we do to prevent and manage, and when we do have, what kind of steps do we take to
Mhm.
figure out what happened and how do we prevent that from happening in the future is valuable for our listeners. So thanks everybody for watching today. The Midland Health Podcast, healthcare that makes you proud. Remember, subscribe to our channel, whether you're on YouTube, Spotify, or Apple Podcast. Drop a comment. Tell us about topics you want to hear from. If there's any guests you want us to bring on, please let us know, and we'll do our best to make that happen by the end of the year. And go be healthy. Thank you.